So what I'm saying is sleep is really complex. And I hope that I've tried to make it slightly easier for you to understand here. There are multiple conditions, lots of overlap, and different ways of people experiencing these things. People are different. Some people are very sensitive, not sensitive. And so even though you have one condition, it can affect two different people very differently. There are lots of risk factors. I've talked about puberty, menopause, pregnancy. You can have being male. Women have the advantage of having estrogen in their bodies. That makes them more elastic. So you need to be more elastic so you can have a baby. Everything stretches. Imagine a man going through pregnancy. Everything would tear, but it doesn't happen to women. But once you hit menopause, after menopause, the girls catch up with the boys very quickly in terms of how much obstructive sleep apnea they have. And you could have all sorts of risk factors, acromegaly, people who inject themselves with growth hormone, diabetes, all these things. Weight gain is one of them as well. If you do gain lots of weight for whatever reason, cushions and things like that, you get sleep apnea. But you have to be relatively quite heavy, sort of a morbid obese before it really causes sleep apnea. Multiple side effects. You can have heart attacks, strokes, depression, all those things I talked about earlier. Multiple treatment options. I tried to give you a flavor of all the different treatment options out there. There's loads of things. Positional devices. I should have told you about my pillow. I've got the first prototype, and I messed up my kids laughed at me because I messed up some of the numbers on my pillow. And the Chinese factory is so nice. They've given me a free pass. They said, look, you can do it again if you want to. I spent so much money on it, and I said, I've messed it up. So very kindly, they said to me today, look, you can have it again. Don't worry, we'll make you a new one. So they've taken it really nicely. So hopefully we'll get that first pillow out soon. And the reason for I want to make a pillow is because people want to sleep on their side. It's because positional sleep apnea, like that person I told you about, when they sleep on their side, they don't have sleep apnea. That lady had other problems on her side, but a lot of people don't have any problems on their side. And if they sleep on their side, their ear hurts because it's pressing here. You get hip bursitis, you get a numb shoulder, you have to roll onto your back, and your neck hurts, and all sorts of things. If you've got CPAP on, it's very hard to sleep inside. It keeps leaking or getting knocked off your face. So I'm making a pillow that will help all of those things. And fingers crossed, it'll be out in the next 2 months, 3 months. I don't know how long. I keep saying this. I'm so excited, but it'll come out soon. It'll be my first iteration of it because I've got the really advanced version happening in another factory. But these are the ones I want people to be able to buy easily for very cheap. The really advanced one with all the bells and whistles is really expensive already. But I think a lot of people will benefit from this rather simpler one, which will work better than I think any other pillow on the system on the market at the moment. And there are multiple specialists. Look, I am nowhere near good enough to look after all sleep apnea patients. I'm good at my little thing, which is sleep apnea, surgery for sleep apnea. It accounts for a small percentage of people out there. We need all sorts of people in the treatment of obstructive sleep apnea. And because sleep is so complex, I'm trying to do this MDT thing. And I want to bring it to the NHS. So this is my plan that I've set up. If you can read it, at the top here is investigation. So what I'm going to do, instead of every single specialist repeating or doing new tests every time they see a patient, I want to do all the tests. So a person comes to see us in the MDT and says, I've got really bad sleep apnea problems. I say, great, you're our kind of person. We're going to do loads of sleep studies. We do 3 NOx T3Ss and a SMED with a video and everything. So 4 nights of sleep studies to try and get as much information as possible. Actigraphy, 2 weeks of ECG to pick up the arrhythmias. 88% of people, there's an 80% greater risk of getting arrhythmias. All sorts of things, cardiac MRIs, head and neck MRIs to look for obstruction and things like that. And do a drug-induced sleep endoscopy. All these things, DEXA scan to see visceral fat, because visceral fat, the fat around organs, also happens to be in your tongue as well, makes your tongue fat. And so losing weight, which is one of the things that people talk about in terms of losing a certain amount of weight, those injections and those pills, Ozempic and the other new one that's come out, I can never say the name, they're really good for losing weight. I'm not saying they're bad, but they're not very good at visceral fat compared to HIITs. If you know what HIITs is running upstairs really, really quickly, sweating crazily for 5 seconds and walking down the stairs again, and then doing another really intense bit of exercise. That sort of thing is really good for shrinking down visceral fat. So that's one thing you should think about. Once we've got all those investigations, seen how much autoimmune screen, we've got like hundreds of blood tests. Once we've done all that, then we go into the assessment phase where all these specialists will see every single patient: respiratory, ENT, me, sleep neurology, max fax for the sort of dental facial skeleton stuff. So we've got a chap who will do MMA, which is bringing the whole face forward, or expanding the palate. All that stuff is available on the NHS in England and in London, sorry. We've got one of the best psychiatric insomnia doctors in the world, Hugh Selsick, weight loss bariatric, weight loss clinics, bariatric surgeons, fitness, personal trainers, all that sort of thing. My functional therapists. It's catching up with the Americans, but we've got as good as we can get. We're doing as well as we possibly can with myofunctional therapy in this country. Cardiology is really important. Remember all that stuff about arrhythmias, heart attacks, strokes, things like that. Endocrinology, because there've got to be people out there who are interested in menopause and other parts of our lives, and also diabetes and all those other things. And we need a GP as well to coordinate all of this stuff. It shouldn't be just me looking after everyone. We need someone who really understands medicine. I don't know anything about medicine. I'm just a surgeon. I like this stuff, but I'm nowhere good enough for all of this. So once we've got all the tests, this is the investigation phase, then the assessment phase by all the specialists, we're going to sit down together on a round table sort of thing and discuss that one patient and say, well, they've got this, they got this, they got this. How are we going to fix this? Well, we should do this. Well, we could offer this. We talk it through and say, these are all the options that I think will work for you. Because I don't know anything about max fax. I don't know anything about myofunctional therapy. As I've said, I don't know anything about insomnia. But if we all work together, we'll say, why don't you fix the insomnia? Says, well, the insomnia person says, well, no, you have to fix the sleep apnea first. So all that stuff needs to be figured out in this meeting. Then we'll give that report to the patient and say, instead of you seeing multiple different clinics and trying to work this out for yourself, here's a big report from all of us. This is what we think you should do. And then if you want us to fix it, we'll fix it. And they may decide not to, or I don't want an operation, then we'll cater it to the person. Once we've done all those treatments, say 6 months, 9 months later, because often it takes that long for everything to plateau off and get better, then we reevaluate, do all those tests again, see if they got better with their sleep studies, look at all the blood tests, because you're looking for something called oxidative stress. When you're really stressed in your body, you see lots of markers like your CRP goes up and tumor necrosis factor goes up. All those blood tests that shows that you were really bad before and now you're a lot better now, rather than just a sleep study, which is quite variable from night to night. And at the end, we say, look, you've done great. You've got rid of your sleep apnea. You're breathing well. You're sleeping well. You're waking up refreshed every day. If you want, we can look after you every year, every 2 years, come back and we'll do a few tests that we think are important just to maintain your good level of sleep and make sure you don't slip back. Because a lot of people do that. I see lots of people, like traders, typically. Traders come in, they fix their sleep apnea, they get great sleep, really refreshing sleep. And afterwards, I see them and I catch up with them later and say, it's been a year and your sleep study is not looking great. And I say, why? Has my sleep apnea come back? I feel great. He says, the sleep study isn't looking great because you're not getting enough sleep. You're only sleeping 3 hours a night. And these traders, what they do, they were struggling with 8 hours sleep, and they woke up and they've dragged themselves into work and tried to compete with their colleagues and making the most amount of money. But when you fix them, they go, wow, my sleep has such high quality now. I only have to sleep 3 hours. And so you really start abusing yourself and you start going out late at night and smoking and drinking. You start slipping back into those old ways that cause sleep problems in the first place. Alcohol's terrible for your sleep. It stops you from dreaming and you can't learn new things. And I can go on and on about that, but I'll skip on to the next thing. So what can you do?